So welcome everyone. This is only the second PLT session that we've run as the Staffordshire Training Hub. Although in a previous version of my life, I think I used to head the PLT a few years ago, so I'm sure there's a little bit of continuity there. So we are obviously trying to look at things that are a priority and difficult to manage, and we're very happy to take suggestions. But one of the things I think we've had quite a few bulletins about is about opioid reduction and various other things. So it seemed very timely that we asked Sharina and her colleagues to talk to us about that, and then with some gentle arm twisting, because it was very short notice. I'm very grateful to David Palmer and the Turning Point team to talk about their work with that they're doing as well with the inclusion team. So we've got a really packed afternoon with 6 speakers. We will have a short break at about 3 o'clock if everything runs to time. And at some point we'll put a QR code in the chat so that you can give us some feedback, which is really valuable to us. And as I said, very happy to take suggestions for future meetings. Just as a heads up, the next one, obviously we were slightly more organised than Rishi Sunak, but it happens to be the day of the general election is the next protected learning time. And we have a super afternoon then where Red Whale are doing a menopause masterclass. So some of you may have been to the menopause ordinary one. This is like a sort of an advanced super menopause course, but everyone is welcome to it, and I think that will be really great. So that's on the afternoon of the general election. There'll be slightly different joining instructions for that because you do have to register for that through Red Whale, but that means you'll get access to it for a year onwards. So I'll remind everyone again at the end, but that's where we're up to. As usual on these things, if you're not a speaker, obviously if you could keep your cameras off and be on mute, that would be brilliant. Unless obviously you want to speak. Sharina's indicated that they have a question and answers planned for the end of their 3 presenters. If you are like me and might forget your question, and obviously put it in chat and we can come back to you. So as I say, really nice to see lots of familiar names appearing on the meeting there. And without further ado, I'll hand over to Sharina. Thanks very much.
Thank you very much, Sheena. I'll just share my slides, and it's wonderful to be in a community of practice. It's been a long time since I've met my GP colleagues for such a long time. So let's see, can you see the screen now?
Yes, we can.
Okay, so I'll start. Okay, thank you very much. I'm here to talk a little bit about prescribing in chronic pain, but primarily looking at opiate deprescribing. As a meds team, we've been working about 2 years on this, and we just want to share some of those developments that we've been going through. So today, I'm just going to talk a little bit about the background for this, and Lauren is going to talk about the most important part, which is about the conversations that you need to have with patients around this to engage with them, and then Renee is going to talk about the resources that we have for opioid deprescribing, which we've been working over for the last year or so. So you'll notice there's a bit of a plant theme here because I'm a great gardener. I was fortunate to go to the Chelsea Garden Show, and it was fantastic. So that is going to run through because it's a good metaphor for change and growth. So starting really about how did we get where we are? So a bit of background. So we have this like very humble thing, Paparum somniferin, a little poppy seed, which over time has sort of was been used for thousands of years, for many historically for whatever reason, but over time it's been used in as an isolate in surgery and so on. And you'll see the checkered history going forward, that primarily the use was very much for anesthesia, pain post-surgery. Some of the alkaloids were developed, but the clinical change really was in the 80s when the destigmatization of prescribing for chronic pain started coming through with sort of published medical literature, sort of the darker aspects of pharma company working with industry, to a problem where we have the opioid crisis in the USA. So that's a very rapid position of where we are. So the clinical use of opiates in chronic pain has been destigmatized, and where we've been very hazardous before has now been, created to use this. So this is where we are right now. And from 2018 to 1998 to 2018, there's been a massive increase in opioid prescribing in the UK and post-COVID as well. So what didn't help was that how do we communicate and managing chronic pain? So this pain ladder, which was primarily used for cancer pain, was often used for chronic pain. And I remember in my years of, earlier years of training saying, not to be worried about addiction, that, people with pain aren't affected, but this isn't true. The significant issue with this pain ladder is that we don't have de-escalations going down. There's issues, it seems to be very unidirectional, and there's all sorts of things around it. But the key message is that we know that it's good for acute pain, but longer term chronic pain, it isn't. And the 2 to 4 weeks is likely not, if pain relief isn't relieved within 2 to 4 weeks, it's not going to have any benefits. But the key element in this pain ladder historically is that the biopsychosocial element of it and the non-interventional has never been integrated into it. So that's where we are. So the main points going again is that we have a huge burden of patients suffering from pain. You and I, at some point, we will be affected by it. The Faculty of Medicine talks about what is a minimum amount of load that won't yield any further benefits than 120 milligrams. So that is the high-risk group where the harms and the benefits overlap. And we've done some work locally about that, and we'll talk about it. National team have been also looking at work around chronic pain, and they said that one of the things that you can do is to look at reviewing patients, and by reviewing at least 62% of 62 patients, that the mortality of reduction is reduced by one life by, sorry, I haven't expressed that properly, by reviewing the analgesia. So, and then T is about 62. It's quite significant. The biopsychosocial elements are the key elements of this, and the shared decision making and the validation, the support, and the relationship that we have as an MDT team to our patients is really key. So the evidence has changed and has been re-examined, but it leaves a picture of where we are with this and how do we tackle it. And the only way forward really is a whole system approach, because it is complex. And the key element is the role of primary care in this in terms of supporting that. So nationally, what has happened is that as part of the World Health Organization raising this in terms of reducing harm, this was part of the priority of the National Med Safety Program. And one of the things that they talked about was a whole system approach. And this was the approach that we took in our area to try and tackle this. So you're probably wanting to know, where are we as an ICB? Well, we are probably the second highest prescribers of opiates nationally. So we're second below Wales. So that's quite a stark reality of where we are. And that's primarily because quite a lot of the other areas have been focusing on it. So nationally, the prescribing has been going down, but ours has been going up. So our burden for prescribing for opiates, long-term chronic, is quite high. It's about 24,000 patients who are on long-term opiates in the ICB, of which about 1,800 are on high dose, so that's a high risk. And we also have a mixture of co-prescribing, which again exacerbates that risk to patients in terms of harm. So high dose opiates, I mean, there's one area that we had worked on last year, and it does show a decline, and this follows the national trend. So this is a good news in terms of that we are focusing on looking at our high risk groups of patients, and that's a positive thing. So as I mentioned last time, we did last year, because of the situation, we did an audit, a baseline audit on prescribing and proxy measures of prescribing to see where we are. So this is the outcome of that audit from last year, of which this year we want to maintain those improvements. One of the significant thing that we picked up was that out of the patients who are on high dose opioids, that means greater than 120 milligrams, 50% of those groups of patients didn't have a clear indication. So the purpose of prescribing without an indication is sort of is difficult. So that's one of the key improvements that we want to try and look at. The other thing is that as part of the CD review, that there was very few patients that had a treatment plan or a review within 3 months. So only 90% have had that. So that's another improvement we want to try and do. And there's a whole bunch of co-prescribing as well within this that also needs addressing. But the interventions made also highlighted that the harm, the difficulties in primary care that we have in terms of dealing with this situation. So as part of that whole system approach, the second intervention we did was to look at primary care stakeholders to understand, what are the barriers. So about 22 PCNs participated in this, and this is the summary of what we've found. Was obviously the concern of lack of commission services, that patients are stuck in this hole in terms of managing pain. GPs are supporting to alleviate that distress, and this is where we are. The difficulty in terms of patients understanding and unwilling to taper, and
Sorry
the
to
lack of
disturb
time.
you.
Yes.
We're having difficulty hearing your voice. Would you mind just moving your settings, or just it's...
Sure. I'll speak louder. Does that help?
That's better, thank you.
Okay, thank you very much for that feedback. So the third intervention that we also did was system mapping, which was to try and understand where we are. And this is quite a protracted piece of work. So this isn't new to many of the clinicians out there, that, we have a variation in services which is being addressed by the providers. We have long waits. We also have drugs and alcohol team, where we don't know how we refer patients in for patients dependent on drugs, and that's something that we're working through. And also the role of local authority and community voluntary groups in supporting the biopsychosocial aspect of pain. So the wider aspect is also the link and deprivation. So one of the things that we would like to do is to do the population mapping, but these are some of the characteristics of some of the risks around opiate deprescribing that accentuates it and makes it more difficult. And this is something that need to be borne in mind in practice. So going back to the whole system approach, we're on the phase 5. And I'm going through this very quickly, but we have a system-wide core group with all our providers and various things to sort of go through the action planning and try and focus on what is important and how do we get a plan together. And you will see here that we've got these 5 circles here. And this is made by the national team in terms of looking at the evidence to see what makes a difference in a population in terms of change. So finding chronic use and tapering support were the ones with the significant evidence, but similarly preventing initiation, de-escalating, sustaining change is also important. So going forward, the key areas for our work has been listed on one, public health awareness. So it's preventing initiations, having a contract, looking at the discharge audit in terms of the interface. So we're working with our secondary care professionals to look at post-operative, pre-operative type of care, and also the process that they have for discharge and opiate prescribing. But the most significant thing for change for primary care is the work that we've been building on, which is the service level agreement for 24-25 around opiate deprescribing, which is a phased 2 stage program, and also the resources and the guidelines that we've developed to support that. So we're going to talk a little bit about that bit. So in terms of quality improvement, what we want to try and do is make some incremental changes. So the first phase for us in terms of the SLA, which all the practices have received, is to look at systems and processes, because that is the thing that keeps us safe. How do we look at our CD drugs? How do we process the prescriptions? What do we do in terms of supply? What's our policy that we have? So these are the basic fundamentals of scoping what we do in practices to look at that. The other one is also identifying the patients that are excluding palliative and the various other groups to know who they are, and also to make sure that we're clear about the indication. So that's the first phase of the work that we wanted to do. The second part is the one that we're going to do later. Once that opioid register has been created, the second is to run the search and to then start the awareness raising of, one, sharing the risks of harm, and secondly is starting to introduce to patients the idea and the concept of tapering. And that is what primarily the first stage of that SLA is to drive that improvement and see some changes. So in terms of outcomes of what we wanted to do as part of that change is to increase the patients that we have with a coded indication, is to ensure that patients that have a controlled drugs review past 6 months, making sure that patients have harms of understanding of opiates, and also about the self-management strategies, and an introduction to come back and talk about tapering as needed and supported by the practice. Sorry, I've sort of flipped through that very carefully. So for us, the outcomes that we would want to have is to make sure that patients are aware and supported to have those conversations about tapering and take that forward. And in addition, the only way that we can actually monitor this is through the NHS-BSA indicators, and also looking at population modelling in terms of variation inequalities, which we will be doing. But the key element of this is the co-production and the biopsychosocial support. And this is the idea of the pain cafes and the pain management group. So we've been working with, as part of the group, is to try and understand what that would look like. And we've been fortunate to have about 49 pre-funded places to support this training on living well with pain training. So we will have at the most about 42 graduates of this program, which what we want to do is to start developing that co-production with patients and to have peer groups to start understanding and supporting patients for self-management, really. And this is one of the developments for this year that we want to try and vision for the area. Whoops, gone through very quickly this. So apologise for that. So one of the things that we have done with the Academic Health Research Network is to set up a webinar in looking at this. What is the best way of supporting patient groups in supporting chronic pain? Because this is something, this is a lifelong that needs to be done and to be co-created with PCNs. So I'm sharing this with you so that I'm hoping that more of our GPs and colleagues and others, multidisciplinary team, can attend so that we can try and figure out what we do as the next stage. So not having very much luck with this. So in terms of next steps, the sustainable change, the main things that we've done as a health organisation is to look at quality improvement. So knowing what we know about the audit and our prescribing, the only way forward is through primary care and through incremental changes. So the SLA is a significant part of that. And with that comes all the resources that supports deprescribing, which Renee will talk about later. The other thing is really looking at scoping pain management. So pain cafes or peer support. So that's something that we would like to work with PCNs and multidisciplinary teams to raise that. The other part that we're trying to focus on is the public health campaign. And we're working with comms to get some patient stories, which you'll see later on today, and also some of the public health campaigns to raise awareness about the hazards of opioids. And the other things is the work around the secondary care and ongoing support and innovation. So that's my bit in terms of setting the scene, really, in terms of where we are. So I'm going to finish now because we'll take questions later, and I'm going to introduce Lauren, who is going to really talk a little bit about the conversations, because that is the most important part, is how you engage with patients to have these conversations about opiate deprescribing. So thank you very much.
Thank you. I'm just going to share some slides from myself now, and then we'll get started. So I'm hoping you can all see some slides from me now. I'll crack on unless you tell me that you can't see them. So it's really lovely to be with you this afternoon. My name is Lauren. I am a specialist clinical psychologist and I work within Midlands Partnership Foundation Trust within the Chronic Pain Management Service. And today my role really is to hold a space to help us to think about how we might begin to hold conversations around deprescribing with patients. So my aim today really is to firstly provide an opportunity to reflect on the experience that we might already have in relation to holding these discussions with patients. After that, I'm hoping that we can offer you a bit of a framework to use moving forwards when speaking with patients about tapering medication. And then finally, just want to acknowledge and have a space to consider how we might hold or navigate these discussions when they don't necessarily go to plan. So those are my aims for today. I'm going to start with a bit of a reflection space. So I'm just going to invite you to think about what have your previous experiences been of holding discussions with patients about their medicines and reducing them. And some of you might be thinking of times where that's gone really well, which is brilliant. Some of you might be remembering times where things haven't gone so well. But I'm just wanting you to just take a moment to connect with what have things been like for you having these discussions to date. And as I'm talking to you and we're talking to you about this idea of deprescribing or reducing medications and having these discussions, what comes up for you when we're talking about this? How do you feel in your body? What is your reaction? And what is your personal, what are you personally bringing to these discussions? What are your own values and beliefs that you're bringing to the room? And what might we imagine comes up for the patients that we're seeing? And you might say to me, well, why does that even matter? And I suppose it's just an opportunity to think about how in healthcare, we don't necessarily get the time to think about the impact that our own thoughts, beliefs, and communication styles in the room with patients, whether that be physically or virtually, has an impact on these discussions. And equally, what that means when patients come to speak to us, what are they bringing? But actually, what we bring and what the patients we see bring has an impact to shape those conversations overall. You know, imagine I've asked you to talk to someone about something that makes you feel quite stressed, quite anxious, quite nervous. The way that you communicate around that might look quite different to if you were feeling quite calm and confident about something, which then in turn might have an impact on how the person you're speaking to experiences those things. So you'll notice that there is a QR code on screen. If you would like to, you can follow that QR code on your phone and it takes you to something called Padlet. Padlet is essentially an online post-it note board where you can anonymously post your own reflections. I'm not going to ask you to share them with us today or anything like that, but it might be helpful for you to see that your own reflections might look quite similar to your colleagues. So it's just a space for you to use if you would like to. I'm going to move on to thinking about a framework that we might be able to use when thinking about these discussions. And really helpfully, there is a framework that exists that is called FRAME, so it's fairly easy to remember. This was developed with a palliative care population in mind, so it's not exactly chronic or persistent pain. It is American, so some of the terminology is slightly different to what we might use, but it does leave us with a helpful acronym that we might be able to remember moving forward. So I've used it as just something that we can hang some of these things on. So the first part of that framework is really thinking about fortifying or building patient trust. When we think about people who have lived experience of persistent or chronic pain, we tend to find that they've had really long healthcare journeys to even be having an appointment with us in the first place. And from that healthcare journey, they will have built a narrative of what that looks like. They might tell us that they've seen lots of professionals over the years. Some of those interactions have gone really well and that professional was really helpful, whereas other ones maybe have been less helpful. And patients like to share with us what that experience has been like. So for us, when we're thinking with people about chronic or persistent pain, it's really important for us to hold in mind that we might already be working with an existing narrative that this person has about their healthcare, about you as a professional, and about what you are able to offer them in terms of their pain. And how do we change that narrative if it's a tricky one? How do we build upon that? How do we improve that? The first thing that I would suggest is an absolute foundation is the idea of being honest, transparent, and managing expectations. In the context of deprescribing, it can feel really tempting for us to reassure patients that if you take your medication, it will be temporarily uncomfortable, but overall the pros outweigh the cons, and we can feel that that is a really reassuring thing for our patients to hear. But actually, if our patients find that what we are sharing with them looks a little bit different to reality, where in reality that might be a really difficult process, that might be a really anxiety-inducing process, if there are differences between how we're describing this process and what it's like, our patients are unlikely to trust us. So sometimes managing expectations and being honest about something and what something will look like can be incredibly helpful. Equally, within all of that, it can sometimes be really helpful to acknowledge how we've got to where we are in terms of medication prescribing. You know, our patients rely on us to know the evidence base and to look at research and to know that, you know, what we are suggesting to them is what we think is the best for them. But in the context of pain, we know that that evidence base has changed over the years. And I think it's important that we acknowledge that we are where we are now, and we spend time with patients explaining why we want things to change and what this process will look like exactly. The next part of that framework is about recognizing patient willingness or barriers to engaging with you in that process. There aren't many people who come to us as healthcare professionals wanting medicines for the sake of it. Our patients will want medicines in chronic pain settings because they want to reduce or ideally get rid of their pain. That always tends to be the overarching goal. And what this means is that when we suggest something that ultimately might be reducing or taking away something that a patient perceives is helpful in their pain management, that can feel incredibly frightening. And we're left with this bit of an internal conflict. Part of that person wants to protect what they know is helpful for their pain, but the other part of them might be saying, yeah, do you know what, I would really like to live my life without as many pain medicines or medications. And that conflict can be really tricky for people to know how to navigate. And sometimes when we have that internal conflict where our values are pulling us in different directions, we can become a bit stuck. And really, we can be almost psychologically paralyzed by not knowing what to do. If the options available to us are so overwhelming, sometimes it can be hard to make a decision, and that makes it hard to move forward. So as a professional, it's our role to help and to recognize where patients are willing to go with us on this process, but what are the barriers that are getting in the way? And for some people, those barriers might be thinking about the future of their healthcare. If I engage with you in this process now and it's tricky, what will this look like for my medicine management? If I say yes to this, will my pain go through the roof and I'll never be able to get it back down again? And really the idea here is when we have a clearer understanding of what gets in the way of someone saying, yes, I'm willing to give this a go, we're more likely to be able to support them to go through that process overall. So I recognise that these first 2 points in this framework involve a bit of investment time-wise, being able to spend time with people, getting to know what's important to them and thinking with them about how they want to move forward. And I entirely appreciate that the time that you might have available to you to do that looks a little bit different to how much time, for example, I might have. But I would encourage you to think about it as a bit of an investment. When these conversations start well and they go well, the results of your tapering are likely to continue to go well. People are more likely to engage with you if they're trusting of you and then recognizing that you're hearing what's important to them. But the next part of that framework is about aligning. So really helping our patients to see that our goals as healthcare professionals probably aren't too dissimilar to the goals that they have as patients. I said earlier that working in a pain service, the goal I hear all the time is, can you please just get rid of my pain? And of course, absolutely, we would love to do that if we could, but very often pain management is more about offering education about what pain is and shifting that focus from curing or eradicating pain to living well alongside it. So thinking about balancing our agendas here, what is important to us as healthcare professionals as we're pitching tapering or medication deprescribing versus what is important to the patient. And how do we start to strike a balance between the two of these things? So when we're thinking about aligning our goals or our values as professionals and as patients, I think it's really important for us to think with our patients about what might their life be like if they weren't living with pain. What kind of things might they be doing? Where would they be going? What hobbies would they have? What interests would they have? And really, it might be about us helping them to shift that mindset of, if you can eradicate my pain, I can do these things too. I can start to think about doing some of these things despite the fact that I live with pain. So that's where we're going to think about some of those resources that we'll be sharing later that are really focused on this idea of pain management. Really is that biopsychosocial model of living well with pain, of which medicines are only quite a small part of that, whereas the rest of that model is really helping people to improve their quality of life. And when quality of life is improved in the context of chronic pain, coping is better, mood is better, which for most people means that that overall experience of persistent pain feels easier to manage. It doesn't go away, of course, but it does feel easier to manage. The next part of our framework is about how do we manage that idea of cognitive dissonance. So this is when we have values that might pull us in different directions and might feel really tricky for us to know what to do. So I was speaking to you a little bit earlier about this idea of feeling psychologically paralyzed. We might really want to reduce medication, but we might be incredibly fearful about what this might mean for us. How do we manage that in a healthcare setting where people are expressing significant distress at what we're pitching to them? More than anything, the most helpful thing that I might suggest that we offer to people is a space to acknowledge and validate that distress that they're bringing. It's completely normal for people to feel frightened or even upset or angry at the idea that we might be suggesting that something that they perceive as helpful for their healthcare might be reducing. And whilst we might not be able to promise that we can offer an alternative medicine that will absolutely meet all of their pain goals, just feeling heard, validated and supported can be an incredible part of maintaining this process. Just going to invite you to think of times in your personal lives or in your professional careers where you've been going through something difficult or challenging. What has it been like for you when you've got someone there supporting you, cheering you on, validating you, hearing you? You know, does that mean that you're more able to continue with that difficult thing? Does it keep you going? Does it sustain you? And if you didn't have that, are you more likely to stop working towards that challenge or stop or disengage from that difficult thing? And it's really similar in healthcare. Hearing people, listening to people and just acknowledging that what we're asking of them is hard, even though we know it's helpful, but it's hard, can go a really long way in supporting people to continue to engage in that process. And then finally, the last part of our framework is about empowering patients to continue that conversation. I would really encourage you to discuss this process with people as this idea of it being continual. It's not something that we're going to start tomorrow and we're going to finish next month and then we're going to be done. Actually, this can be a continual process that we're constantly checking in and engaging around. And I would invite you to think about how you can share your healthcare professional values and aims, but whilst holding that other person's in mind. And that narrative of this is tapering medication is something that is being done with me rather than to me. And that change in that shift psychologically means that people are more likely to be engaged and stick with something that they have opted into, that they have made decision around and that they have been supported in, versus when they've just been told this is what's happening and this is how it's going to be. So we know that there's incredible value in empowering patients to be able to participate in that conversation. So in practice, this might mean if you are suggesting a reduction at a certain rate and it feels really uncomfortable to a patient, it might be about meeting them halfway. You know, can we book a shorter time for a review just to check in? You know, I'm offering that space, I'm still with you in this process, but we are still hoping to continue to move forward. So really, overall, this idea, the framework is really an opportunity for us to think about the skills that you will already have. You will know how to speak with people who are distressed. You will know how to listen to people who are struggling or who are fearful. In the context of pain, sometimes our values as professionals might feel on the surface a little bit different from our patients. So this is really an opportunity to think about how you might want to navigate those conversations when you're thinking about this with your own patients. And I just wanted to end on a couple of case studies, really. And I guess that these are scenarios that perhaps might feel quite familiar. You know, the first one, this idea is that you've pitched this idea of tapering and a patient has just completely refused to engage in that process. They're really angry that you've suggested it in the first place, and they tell you that it's just another example of another healthcare professional that doesn't care about them and that doesn't understand. Thinking about that framework that we've just been using, just want to invite you to think about how might you respond to that? What might be helpful in the moment? If it was me, I would first and foremost be acknowledging that it's okay that you feel angry that this is something that I'm suggesting, because I understand that at the moment medication is important to you and your overall perception of your pain management, and it's frightening to think about taking that away or reducing that. I might be recognizing that this person is perhaps not quite ready for me to be implementing this process right now. So I might suggest to them, perhaps you can go away. I will give you some literature. You can read it, digest it, process the conversation that we have, and come back soon and we can have a talk some more. Think about whether you've got any questions for me that I can answer for you. So that idea of building trust, managing expectations, offering that space to validate and to hear. And I would just allow this space to be for now and just hear what the person is saying and acknowledge that actually right now to push this person at this current moment in time into this process perhaps adds to that tricky narrative that they might have, versus if they're given a little bit more time to have a think about what this might mean for them, what their own willingness and barriers might be, that can be really helpful in guiding how you might gently begin that process with them. The second scenario is someone who is going through the tapering process and up to date it's been fine, but actually they're coming to you and saying that their pain has significantly increased and actually they're really struggling to cope. You've told them that this is a temporary change, but this person is really struggling to hear that right now, and they've asked you, can we stop? Can we stay where we are right now? Again, the skills here are going to be quite similar. We're going to be listening, hearing, validating, acknowledging, but perhaps in addition to this person, we might be saying, you know, let's spend a bit of time reflecting on how far you've come. You've done so well. Look where you started, look where you are now. You know, that idea of really championing what that person is doing. And this is where we might start to strike some of the balance between our own values and that person's values. And we might suggest, okay, we can pause this process here right now and let's review it in a month or so, or you know, whatever that time frame might be. Let's just sit with this for a little while and see where we're at, and just offer that person just some time to just be in this process without immediately pulling them out and saying, yep, okay, we can stop, but without pushing them before that they're ready to be pushed. So the skills with these two scenarios, they're ever so slightly different, and I entirely recognise that I've probably not shared a particular skill or a strategy today that you don't already know. You know, you are all skilled clinicians who have hundreds of client and patient contacts all the time, but sometimes it can be helpful to hold in mind just some of the things we might want to weave into our conversations when we're thinking about pitching something that somebody else might experience as quite fearful. So that's it from me today. I think we're going to take questions at the end of all three presentations, but I do hope that has been helpful to you in some way, and thank you so much everybody for listening. I have provided a reference here for the framework, so you don't have to hold it in mind. We will distribute that out to you, but thank you so much.
Right, so I am going to do the next bit, hopefully. Let's share the screen first. Okay, so Right, okay, can you see the presentation now?
Yeah, that's fine.
Excellent, thank you. Right, okay, so I'm just going to go through the tapering resources that we have created. So before I start, I just wanted to give a little bit of background about the resources. So they're all based on resources that's already in use by other ICBs, or as CCG as they were at the time, across the country. But we have amended them slightly based on advice from a core group. And our core group had represented from MPFT and UHM pain teams, as well as substance misuse team, GPs, and feedback from pharmacy teams and patients. Saying that, our work is constantly being reviewed and updated, so if anyone has any feedback, we welcome that. So I'm not going to go through the background in great detail because you've already heard most of it from Sharona. I just wanted to, you know, highlight the fact that the essence of all this work is about safety and not saving money. So the resources that we have developed include a tapering pack, which most of this presentation is around the pack itself. At the end of the resource pack, there's some links to helpful sites, which I'll mention a bit later. We've also created a few leaflets. Some of them are available on GP365 at the moment, and a couple are in development. You can link that to the SLA work as well. We've also created an appointment letter which you can amend, and reducing charts that again you can amend to suit the patient. So the resources are available on GP365. So they're under medicine optimization, and there's a little blue box in the corner with resources, and there's Deprescribing resources there. Now, if you click on that, that's further split into a file with the reducing charts, and there's a chart for most of the different opioids that you can prescribe apart from buprenorphine patches, which I'm still working on. So you can just amend these to suit the patient. There is also consultation resources, so there will be any diaries about goals or exercise or pain management. It's illustration, and there's some leaflets about self-management you can provide for the patient. And there's also an opioid agreement in there if you wanted to introduce that before starting opioids. There's also, again, as I mentioned, some leaflet about pain and opioids, and there's pre-appointment resources. So that would be the invitation for the review. There's a health and well-being questionnaire and a medicine decision guide, which could be useful to send to the patient before you have the appointment, so that they have time to think about what's important to them. I just want to let you know that the actual resource pack itself isn't on GP365 at the moment, because I had to upload all the individual resources so I can link it to the document, but they should be there shortly. We're also trying to create something to have available on the ICB website, so that patient can access that directly, and that will have link to patient-facing resources. And that will also be linked to in a separate leaflet we're creating together with MPFT. So if you are then planning to do opioid tapering on a larger scale rather than just ad hoc appointments, we recommend that you do a little bit of preparation before you start, just to increase the risk of success. And that's based on feedback from teams that are already running these sort of type of clinics locally. So first thing, decide on who's going to be the main person doing the reviews. And that's to both create a bit of structure for the patient. These patients often tend to be a bit anxious about getting their prescription and any changes, so having that structure is helpful. And also, if you've already had that discussion in your PCN practice, then you avoid others, you know, undoing any of the work that you've already done. Decide on what sort of patient group you're targeting, if you're looking at high dose patient opioids, or if you want to look at patients that are already prescribed other dependence forming medication. Look at how you will do it. Is it going to be a virtual appointments? Are they going to be face to face? Will it be a mixture? Some practices are doing it one-to-one, other practices are doing it as a group exercise, and there could be GPs, pharmacists, social prescribers and physios involved, and there are different pathways you can do if you choose that model. A suggestion has been to send out the health and wellbeing questionnaire for patients to complete prior to the appointment, just again so they have a chance to sort of think about what's important before they get to that appointment. Alternatively, you can provide it at the appointment, depending on how well you know the patient and how they're going to react to what's happening. Also look at who else is in the team that can help out. Patients with pain often suffer other things as well, so poor diet, low mood, isolation, sleep problems, etc. So who do you have in your team that can help out? Do you have social prescribers that can help? And if they don't have capacity, can they provide you with some resources or to local services that you can yourself signpost patients to? Do you have any physios that can help with gentle movement? Or if diet's a problem, is there a dietitian that can help out? So again, in addition to familiarising yourself to local resources, then have a look at the online resources in the practice. There's a lot with regards to both as self-management strategies, about resources to tell you about pain and so forth. And also finally put a process in place for the initiation of new dependence-forming medicines. And that can also be linked to our SLA for this year. So not everyone is suitable for a review, and the resource pack has some suggestions of examples of patients that you could review. So the most obvious one, and probably the least likely one, is patients requesting a review themselves. Other examples include patients who are still complaining about pain despite being on opioids already, patients who have side effects or where their day-to-day living is affected by opioids, or patients that have been on opioids before surgery and now they're far enough down the post-op line to finish or start reducing their opioids. You also have conditions that either might spontaneously improve or they go in sort of waves of you have pain and you don't have pain. These sort of patients might be more suitable for PRN opioids rather than modified release, which is linked to higher risk. Obviously, any evidence that the patient is diverting medicine needs to be reviewed. High dose opioids and patients on other dependence-forming medication are at increased risk, so they should be prioritised. And obviously, if they are at risk of harm due to other comorbidities as well. So for the initial appointment, obviously, this is going to mirror a lot of what Lauren said. And she's one of the people that's helped us create this guideline. So it's got a lot of ideas of what can be discussed. You just need to keep in mind that obviously it's a holistic review, so what you discuss will depend on the patient. These are just ideas. And also remember that for a very small number of patients, that it could actually be appropriate for them to stay on opioids, either at the same or a reduced dose. So to increase the success of this first appointment, we do recommend that you clearly state at the beginning that you're not planning to change the medication at that appointment, just to get the patient to relax a bit, because if they come in their head, they're probably going to think, well, they're going to stop my medication, and then they won't really listen. So we recommend, again, to start off asking the patient to tell you about the pain and what's important for them. Which is why we mentioned the health and well-being questionnaire, and also find out a bit more about how the opioids is affecting the pain and the function. If they say, for example, that they're still in pain despite being on the opioids, that's probably an indication that they're not actually working. Check if they have any unwanted side effects and their general views about opioids. Also see if they've tried to stop reducing opioids before. This could be if they've tried to stop because, for example, they ran out of medication, they could have experienced some withdrawal symptoms. That could be a barrier. So explore their fears and explain that, how we're going to help prevent withdrawals by reducing it slowly. And if there was any withdrawals, we would pause any further tapering. So it's just about putting their minds at ease with regards to that. Equally, if they have side effects or they're concerned about long-term harms of opioids, that might be a motivation to start tapering. And as Lauren mentioned, one of the biggest challenges with opioids that obviously these were started at one point, and they were probably told that they needed these and they were safe to use. And at this stage, we're now saying something completely different. So it's probably important just to explain that, with any medicines we have, we gather evidence as we go along. And when opiates were first put on the market, we did think they were safe and effective because that's the evidence we had at that stage, because they hadn't been used for a long term. Whereas now we know more about them. We know that they don't often work and there is a risk of harm. It's just about being honest and transparent. If you go through side effects, for example, it might be useful to use a visualization. So, for example, side effect lottery, which is part of the resources, you can print that out and personalize that to the individual patient. So instead of just listing all harms, just think about who you got and what they've already told you. So, for example, an elderly patient might be a bit more worried about falls and fractures, so mention those side effects. Whereas other people might be worried about the effect it has on libido, reduced fertility, depression, and also the chance of opioid-induced hyperanalergia. Another way of exploring side effects is that there are other visual leaflets in the resources that you can use to go through the different side effects and highlight how that could benefit the patient if they were to reduce opioids or stop opioids. Going forward, is all again about managing expectations and be honest, explaining the process of tapering, saying that it's going to be tailored to their needs. It might take several months, and that in the long term, most people who do gradually reduce ineffective opioids don't experience any worse pain. They might even feel better because they could have had side effects they didn't even know about. However, in the short term, some people might have increased pain, and that's just their body adjusting to the change. And that the plan is for us to help them manage that by the various resources that you've got available to you. You might want to share any success stories of people that already done it, if you have, and then explain to them that the aim of tapering is not to substitute opioid with different medication, because there isn't an alternative class of medication that are likely to be effective in relieving long-term pain. At this stage, if appropriate, you might want to refer to anything you have available locally. So if you have a PCN mental health practitioner, or if not, self-refer to talking therapies, if this is appropriate, physiotherapy for exercises, social prescribers for local distraction activities. There's also a fair few self-management strategies available in the resources. And obviously you do have, for most of the patch, you've got the pain management services. But again, manage the expectation that also they will also focus on self-management strategies rather than pharmacological treatments. You might want to explore if they have any support available for family and friends to make sure that the patient is not isolating themselves, which is high risk for patients with chronic pain. Use the shared decision-making approach to agree together what you want to do. If opioid tapering is available, if they want to go away or think about it and come back with questions, and then agree on what the goal is. Is the goal to stop opioids, or is it just to reduce it to a dose that has a better risk-benefit ratio? And then obviously, finally, just agree and clearly document anything that you have decided. So for the actual first appointment where you talk about how you're going to do the tapering, the first thing we would recommend is see if the patient's on more than one dependence-forming medication, or if they're on more than one opioid, in which case, which one are they least attached to, or which one do they feel is the least effective, and then start with that one, because that will build their confidence in the process. And reducing any other dependence-forming medication will eventually reduce the risk of harm from opioids as well. Tapering should be individualized depending on how high the dose is, how sensitive the patient is to change. Some might be more confident in using faster, whereas others would like to have it slower. Now, the core group I mentioned, they felt that the most easiest, convenience way to do it would be to reduce it monthly, which is the normal prescription frequency. Obviously, you can reduce it faster if that's what the patient wants, but we don't recommend it being done more than weekly. When it comes to reducing the actual total dose reduction, the general recommendation is about 10%. Chances are you probably will go slower, especially initially. Whereas when you come to the final stages, tapering is usually faster, and that's just because they're just not at available doses to make it possible to go at 10%. But again, the the reducing schedules that we provided will have a list of available strengths, and it'll go through. I can show you one of the ones in a minute. The second part is to agree the frequency, whether or not you're going to see the patient face to face going forward, or it's just going to be a phone conversation. Also agree how they're going to get the prescription, as this could cause some anxiety. Highlight that you're the only one who's going to be prescribing for them, and that all the things that important points from the first appointment where you talked about that the tapering is tailored to their needs. It's going to be slow. We're going to take it. It will take several months to do it. And the short-term pain might increase for some, but it will stop because the body's going to adjust to it. But longer term, most people do feel better due to less side effects, and the pain shouldn't be worse. And then again, highlight some of these useful self-management strategies. Document clearly anything that you have agreed to do, including when the next prescription is due, how it's going to be issued at the appointment or between appointments, how the patient can then get a hold of a prescription. Then provide a copy of the plan, book the next appointment in, and provide advice what they can do if they need anything between appointments. General prescribing notes is just make sure that they're on acute, added dose and amount each time. You might want to say that this is to reduce the medication as per reducing regime, and how long the prescription should last, just for ease for the patient. Now, for any follow-up appointments, the recommendation is to always reduce symptoms and progress. Ask about any changes in side effects, mood, function, but always try to focus on the positive. Have they reduced their side effects? Is there any improvement in alertness? How is the function, and how are they feeling generally? Now, if they say that the pain is worse or the function has been reduced, then explore that with the patient and find out if this is part of the normal pain window for them. So does the pain normally fluctuate, and is that the case now, or do they feel that the pain is different? Check if there's anything new has happened. If, for example, they might have taken up some exercise and that might be causing the pain. And finally, just make sure there's no new symptoms or new pathology which needs to be investigated and treated separately. So after you've done all this, as Lauren talked about, just acknowledge the fact that they are having a difficult time, and explore any strategies that you can help them cope with this, going through the difficult time. So have they tried, for example, distracting techniques like music and mindfulness? Is there any safe exercises they could potentially do? And if so, do they need a referral to physio? Have they tried any of the self-management tools that are provided by Live Well with Pain, or pain tools? At this stage, it might be suitable for you to print something out because they might not have access at home to the internet. And also, is there any change of mood? And then consider signposting them to listening services or Samaritans. Again, manage expectations, saying that they're not going to be able to do anything about the pain medication as such, but they could there could be someone for them to talk to. And then at the end of that, just review the risks of benefits of continuing opioids. Do you need to hold the tapering dose? it might even be suitable in very rare circumstances, and if it's clinically safe, to increase it back up again, all depending on the scenario. But avoid adding any PRN opioids, any hypnotics, or any benzodiazepines. So at the same appointment, look at withdrawals. Just check if they have any withdrawals. If they do, post a taper or review the dose. And then finally, at the end of the appointment, just confirm the patient is still willing to continue the taper if that's appropriate, and discuss the rate of tapering if that's still suitable, frequency of reviews, and then book the next appointment in, provided a copy of the tapering plan if it has changed. So in this resource pack, when it is available, there's links on there to understanding pain. So these are links that you can send to the patient by AccuRest messages. There's links to exercises, mindfulness, available local services. Again, as we mentioned about the listening services, Samaritans, there's links in there to that. There's all the leaflets that we've developed, as well as some of the resources that Live Well with Pain have produced. They're available on there. And then there's some resources for professional regardless. So the links to NICE assessment tools, all our reducing charts, and any other helpful educational links that we found along the way. So that's it for the resources as such. I'm just going to hopefully show you a message from one of the patients that we've been working with. Do let me know if you can't hear it or if it doesn't work, because I've not tried this before. Let's see, can I do it? Right.
There's no sound, sorry.
Okay. Let's have a look. Oh, right. If I maybe exit the presentation and play it separately, that might work.
I think you might have to reload your presentation, and then where it says share contact, you have to include sound.
Right.
There's a button at the top, but you have to probably come in out of your PowerPoint and come back in.
Right. I could, if I got the video ready here, so I'm going to press play, see if you can hear it.
No.
No, again, if you don't
Okay.
do the share sound, it won't work.
Right. Okay. Okay. I'm not quite sure. So what did you say I needed to do?
So exit from sharing screen, and then when you press the share screen button again, at the top of that there's a little button that you move across that says include sound.
Right. Okay. So
and then that should work.
Share this window. Okay. Share.
Include sound. It's a little button on the top there. Can you see it?
Yes.
Yeah.
Yes. I can see it. Yeah. Okay. So then do that one, and from current slide, and then
I've been on opiates for
Yeah.
about 15 years.
Yeah.
Put onto them for chronic pain relief.
So opioids are strong pain medication, and common examples are things like codeine, tramadol, morphine, and oxycodone, as well as pegylated patches.
It's contributed to other problems. So when it's made me constipated, that's caused more pain when I'm on the morphine. The negative parts as well is it can make you depressed. You don't want to be.
Is there any way volume can be increased, because we can't hear anything at all? Thank you.
Yeah. Right. Where am I now? I don't even know where I am anymore. I say stop sharing.
Yeah.
Yeah.
I think we don't. Do you want to?
No, I think it's fine.
I don't think we need to do it now. Yeah.
The presentation is available anyway, so you can listen to it there.
I think we're done now, really, and I just want to thank both Lauren and Renee to help us in sort of trying to share this sort of complex things to you. And we've just got a few minutes, really, is to just talk about, how we take it forward, or to take some questions from you, because it is going to be a challenge. There's no doubt about it, in terms of time, effort, and energy. So I'm opening it out to the wider group, really, to sort of ask us, how you're feeling about this, and what are the challenges that you're going to have in terms of taking it forward, or successes.
Sharina, there are a few questions in the chat that you might want to address as well, and also a request to put the link for the video into the chat so we could watch it in the break, if that was okay. But there's a question about how long do the appointments take, what clinics are running, and that kind of thing.
It's the top of the things. Yeah, so there's something there about UHN providing pain clinics that cover Stoke-on-Trent. Trying to get this raised with the ICB. I think that's somebody responding back to that, isn't it?
Yeah, that was me.
Yeah, it's yes. Yeah, so there's a question here from Dr. Simon about how long are your clinic appointments time when dealing with de-escalating and tapering. I'm just wondering, Renee, you'd be able to better, talk about that.
Yeah, so the feedback we've had from some colleagues that have been running the clinics is that initial appointment will take a bit longer. So some people take 20 minutes, some people take half an hour with that initial one. But the follow-up appointments could be anything from 5 to 10 minutes. So it might be a quick phone call, just talking through, making sure they're still okay. And it might take a bit longer if they're struggling. But generally speaking, about 10 minutes or so, the follow-up ones.
I've got a hand up there from Juanita.
Yes, hi. You mentioned initially that we were the second high prescriber after Wales, and I worked in Wales for a long time, and we have tried similar approaches. We had a nurse that was doing this consultation. That was all she was doing, usually 20 minutes, and she could bring the patients to review them and all of that. Unfortunately, the funding then was withdrawn, and all the work that she had done was absolutely wasted. And it was so disheartening, because then the patients come back to us. We had less time, perhaps, and other doctors were seeing them and going back to prescribing. So, and the point is that even the reviews would take time, all of this, and I think Lauren said that the main challenge, it's all very well doing this, and I do a little bit of CBT as well for patients with anxiety and depression, so I know the principles that you discuss are all valid, and that would be the right way forward, but the problem is always time for us, really.
I hear you, Anita. It is something that I don't think can be done ad hoc. This is something about structured approach, yeah, and actually using your wider MDT team. And in a way, that's why we did the SLA for primary care, as a way of preparing the practices to getting the register, to sort of identifying the patients, to sharing the information, and then getting a team approach. But this is definitely something for the ones that you want, that are positive, that want to do the deprescribing and be supported. It is a investment of time, but one that really yields benefits. We have some practices, don't we, Renee, in the area that do this. I mean, we've got some very good practitioners, so the pharmacists that have been taking this on board around this. But yes, it does take time. I think the key thing is as a practice is to have a consistent approach to it, because that's what the difficulty is. People go to different places and getting mixed messages that, it undermines the work that somebody is doing. Any thoughts from the rest of the group in terms of how, you know, this challenge of deprescribing would be approached from practices?
Consensus can be reached in the practice, and a management plan can be put on the record.
Yeah, I would welcome any, you know, ideas that, you know, you want to share with us in terms of as a meds optimization team. What we're trying to do is, one is understand the training needs of multidisciplinary teams in terms of supporting these conversations and supporting patients to move forward. But the one that we really are focusing on is the biopsychosocial approach, and getting a community of you know, peer group support and so on, and developing that model that you know, we feel that is more supportive for this group of patients, and really is moving forward, really is with the public campaign. So that's going to start next year, but unfortunately the burden of this to a certain extent is primary care, and is how we start tackling this little by little, really taking it forward. So I've got Sheena and David.
I'm just thinking, because I've moved practice areas, and one of the areas I work in is very deprived, and I very much recognise that male older patient who's unemployed and is claiming benefits, and in fact their whole life is around their prescription for whatever it is, codeine based, and their arthritis or their back pain and things, and you're sort of taking away their reason why they get their disability benefit as well. So there's a whole sort of you know, sort of there's more attached to that prescription than you first realise, and I can see that's just going to be for those particular patients, they're going to need a lot of social support and things, because I think they will think that they will be forced back into the workplace if you take their prescription away. It's almost like their badge of honour for their disability payments and things.
And that's how the benefit.
Assessment, yeah.
That's how the benefit agency see it as such, isn't it? That's how they will look at the list of medication that a patient is on and judge the benefit according to the medication, sadly.
That is a barrier then to a certain extent, but I mean, certainly reducing it down is a way of moving forward, but still having the medicines, I guess. It's a difficult one. You try and make improvements, but there's all these blocks in the system to, you know, take it forward. It's really very difficult. David, you had your hand up. Is there any insight from your experience that you'd like to add on this?
Yeah, I totally get the rationale for like high dose opiates and the dangers of high dose opiates, whether it's morphine or certainly with oxycodone, which kills more Americans than car accidents in America. You know, oxycodone is a lethal medication, so it just switching people off oxycodone to another opiate would be a massive impact. From the point of view of prescribing and monitoring prescriptions, is there going to be enough detail in the monitoring to where GPs are switching people from a high dose opiate to either to a lower dose or a more mild to moderate opiate, or they just be flagged up as someone that's still on an opiate? Because those changes could be significant. You've got somebody who's on morphine and you get them down to codeine. Actually, from the risk point of view, they're probably at much lower risk, and you've made a big impact on that. But will they still count out as a chronic pain on an opiate?
There is a few different ways that it's been monitored nationally, which, yeah, some of it won't pick it up. So NHS BSA, they do monitor patients on doses over 120 milligram morphine equivalent. So if you reduced it below that, then that will be picked up. So the risk reduces. And the other way they monitor is total prescription. So obviously that wouldn't be picked up. However, Open Prescribing is now piloting something new where they look at the total morphine dose prescribed in an area. So in which case that would come down and it would show on that sort of data. But I guess it depends what data you're looking at, whether or not. But I guess from a safety point of view, you yourself will know that the dose has been reduced. I think there's been a lot of safety alerts come out with regards to coroners, prevention of future death reports from coroners, where patients have died due to either high dose morphine or a mixture of dependence forming medication, and the coroners highlighted the fact that GP practices are aware of this, but they're not actively doing something. So I think it's one of those, if you try to actually actively do something, you yourself at least, you know that you're trying to reduce a risk. It's not always going to work. It's not going to work for everybody, but it's one of those that you try your best at least.
I mean, the way that we're collecting data for the service level agreement is very much about initiating the conversation. So we're collecting information on how many letters have gone out to patients, highlighting the risk, and the sending out letters. I mean, normally what we would do is, following on that, is collect information about interventions. We're not doing that this time because we just thought that the whole program is so complex, and one which we can't control externally like this. But it may be that next year, depending on success, we could sort of try and collect that information. It's hard. I think we're looking at proxy measures of prescribing data, David, to sort of look at change. And see, but yeah, it's not ideal. It's not a great way of recording change. Adds more bureaucracy as well.
And we can't. That simple and workable.
Yeah, I mean, I want to sort of bring this to a closure, really, because the only thing that I want to put up on my on the screen is just reminding our colleagues about this webinar that we've got planned in June. So this one is the one that we really want to start developing, this idea of creating a local infrastructure for biopsychosocial support or patient groups, and we've been linking in with public health and with the local authorities in terms of how that is. And what we really want to get is a critical mass of people coming in and looking at the evidence and the improvement and seeing whether this works, whether it's for pain or for other types of support. But this is something that I'd like to just raise to the group. Just please do check in. I think we've had about 22 people from Staffordshire register, but the more that there is, the better, because we can work backwards and create something for that. And I was going to put this up because just ending it on a theme about the investment that we put in, and I think that for us to move forward, we have to be persistent and have an environment that supports it. So we as a team, we've worked with our stakeholders, our system leaders, to look at what is the best evidence-based moving forward, and tapering and resources is the key thing. And this is going to take a lot of time and commitment, and I really would welcome, I really would encourage practices to have, think about this seriously, because I don't want to be higher than Wales at all as a system. It's getting too risky for us. So I'm going to end now, and thank you very much for the time that you've given us to, raise this issue for you. So thank you very much. Thank you.
Thank you, Sharina and Lauren and Renee. I think there's a lot of information in there. I think we're a bit quiet because we're all absorbing it, but it's a lot of work out there. But thank you very much. It was really informative, really helpful, and I'm sure we will share the resources and they'll be spread more widely. But that was absolutely fantastic. I'm going to offer to people that they just have a sort of 10-minute break now, just to stretch legs and DVT prophylaxis and all that, and have a drink and come back at 3. And then David and the Turning Point team will take over at that point. So see you all at 3 o'clock, if that's okay. And thank you very much again for, I know it was very short notice, but they were brilliant talks. Thank you.
Thank you for having us.
telephone call once again to Thomas Pond. Again, no reply, full stop. Please check if the email has been sent.
Dave, did we decide if you wanted questions as it went through or at the end? Sorry.
It may be easy at the end.
Okay.
Yeah, it's going to be quite conversational, I think. So.
Okay, no problem.
It may be the bit more real worldy, but I don't know. I have to wait and see. It's a bit more murky anyway.
You're going to explain your dandelion picture.
Yeah, no, I do. That's the best bit of it, I think.
I won't spoil it. Okay, we are shortly about to restart again, and we're also just for our feedback as a training hub for the PLT, we are, and for our speakers, we are going to put a QR code in the chat fairly shortly. So it would be great if we could get your views on how the afternoon's gone. We'd really appreciate it. And I think just about as the hour changes, I'm going to pass over to Dr. David Palmer, who I'm sure you will all recognise, and probably needs no introduction, but I shall let him carry on his introduction. Thanks very much. Bye.
Thanks, Gina. Thanks for asking me a short notice. Let me admit Sue. Sue's my colleague. As many of you know, I was a GP in Stafford for 25 plus years at Stafford Health and Wellbeing, where we tackled some difficult patients, really. I then, after retiring from the practice, approached MPFT, the Mental Health Trust, concerned that the suicide rate in the Stafford area was something like the 6th worst in the country, and it shouldn't be because it's not the most deprived area. So based on that quite forthright conversations with them, they actually offered me a job, and I'm working with Sue Rigby in a health inclusion service, which will between us will explain about in a little bit. I think Sue's here. I describe it as a dandelion service. Obviously, primary care, secondary care is under a huge amount of pressure at the moment, and there's cracks in the system. And for some of our patients, they're falling through the cracks. And what we try and do as a health inclusion service is work within those cracks. So we're dealing with all the really problematic patients that actually nobody else wants to treat, the ones that the addiction service doesn't want to deal with because they've got mental health issues, the ones that the mental health service doesn't want to deal with because they've got addiction issues, the ones that general practice to some extent doesn't want to deal with because there can be a real pain in the backside. It's problematic, it's a difficult area, and we sort of do the best we can. I think for a lot of our patients, it can just be about keeping their heads above water. A lot of our patients are struggling day to day, week to week, and it's keeping their heads above water. It's not always the best medicine, but it may be good enough general practice. So I've been working with Sue. Sue, are you there? Been working with Sue Rigby. Hi, do you want to come on camera? Then I think.
Am I on now?
Can't see your face.
I should be on now. I had a bit of difficulty getting on, but I should be on now.
Yeah.
Camera's not on, I don't think, Sue.
Yeah. It is on my screen turned on. Yeah.
We can't see on screen.
I haven't got my camera turned on.
No, we can't see you.
Oh, that's a shame.
Oh, there, you're there now. You're there now, Sue. So,
okay.
Lots of people know Sue. Sue's been. Tell us how long you've been working, Sue, in looking after the homeless people.
Since 2013. The health inclusion that is now started off as the homeless service in Stafford, specifically just for street homeless people. But over the last 10, 11 years, it's grown because along the way, I identified that it wasn't just street homeless people. There was quite a lot of other disadvantaged people that were very vulnerable and were at a high risk of being excluded from mainstream health services. And that was because of many various reasons. One, because they lack confidence in navigating around the system. They haven't got the ability or the skills to navigate around referral systems. And that can be something as simple to you and I as not having access to mobile phones with credit on, a mobile phone, It varies. So over the years, the service has evolved to encompass all these other individuals in our communities that struggle really to get anything from basic first line primary, secondary health care to quite complex. So it's quite a diverse range of people that we see with various trimorbidity support needs. So yeah.
So one of the clinics we run is from a food bank in Stafford, where we see a range of people. Some of them are street homeless, other people are quite vulnerable, and got it's an area of deprivation in the middle of Stafford, which I appreciate isn't the most deprived town, but there are pockets of deprivation within the whole town. Other people just feel a bit disenfranchised. Access to mobile phones is crucial now, isn't it? You can't book a GP appointment without phone access. You can't get a mental health appointment without phone access. There can be some issues about people registering, particularly some people who've recently come out of prison. They can have problems with photo ID and having to register as well, which can be challenging. Where else do we see people?
More or less anywhere, basically. We've got our more official locations, like Dr. Palmer says, the food banks, churches, Salvation Army, home visits that we do to those that are in temporary or in accommodations that are at risk or vulnerable. But more or less, I visit, and Dr. Palmer's made to come along with me, is canal barges, canal sides, car parks, lay-bys, Cannock Chase.
Yeah, tents on Cannock Chase, isn't it?
Yeah, we're quite a specialist service, because whereas district nurses will risk assess and decline to go out of some of our most vulnerable accommodations and flats, we will still go, and we will go because we've got a very good rapport with our clientele, so we automatically know what those risks are, and we can work around them and reduce them for our visits and for them to be able to receive the care. So it's quite a unique service that we deliver. But yeah, there isn't anywhere that we wouldn't go, is there really? We do visit.
Yeah, there's one case, we in a shower cubicle, me, Sue, and bizarrely a one-legged drug user, and he was sort of getting really quite emotional because just wanting to change his lifestyle and everything else. Then meanwhile, on the bedroom outside, there was someone sort of sparked out because they just used some crack cocaine, and there's someone else just lying on the sofa as well, sort of thing. So it's a really bizarre setup, nothing like what I was used to as a GP, where you actually you feel quite secure in your consulting room. What do you think of some of the impacts that we've made on, and how do you work with other teams?
We make a huge impact, quite vastly really, across the caseload of the diversity of the caseload. We make an impact on, for example, little old men that's lonely, depressed, isolated, and they'll come to drop in and they'll have a 10 or 15 minute conversation, and you'll jolly them along and you'll pick them up, and they'll go away with a smile on their face and quite happy. The other impacts that we have is getting some of our more entrenched substance users, homeless nurses engaging. That's a huge impact, to get them engaging and turning up at drop-ins. And if you can do that, it's a really good start to them getting treatment. And the reasons why we don't offer appointments is because they're useless at attending them. Most of them DNA appointments, if you give them a day and a time, because they've got no idea what day and time it is today anyway. So if they've got that drop in, they've got a slot to turn up in, and they very much do so. But we've had some huge impacts physical health wise as well, haven't we, Dr. Palmer?
Yeah, there's a lot of
from a nursing perspective, perspective, I'm just about to heal a female over 2 years with bilateral extensive leg ulcers.
And these were like kebab meat. Her legs, weren't they? Her legs were really raw, just like a kebab shop meat, and they've gradually granulated and healed up. It's amazing work. You know, when I saw them sort of 18 months ago, I thought there's no way are they ever going to heal. But actually, they have got a scab covering of skin. They're obviously still quite scarred, but they're now not weeping anywhere near as much.
I mean, both legs were the full circumference of the lower limbs, these ulcers, and now we're down to, I measured on Tuesday, and we're down to 4 centimetres by 3.5 now. That is an example from a nursing perspective of wound care. That's one of our severe wound cares that we have.
We've got that engagement. We got her into treatment, haven't we? She's now under treatment with stars with methadone because actually she sees a future for herself now.
Got her into treatment. We've got her on a methadone script, engaging with wound care, engaging with homeless outreach. It's fantastic, really, how far she's come. There was the other gentleman, Dr. Palmer, that if you hadn't have come out on that one afternoon, I'm almost pretty sure he wouldn't have been with us today. The amputee.
Yeah.
He was really, really poorly. And to be honest, I was really worried about him, and I was borderline sending him in.
And he wouldn't have gone. He had quite nasty pneumonia and is quite poorly, and actually he refused to go into hospital anyway. And we did put him on antibiotics and followed him up quite closely, and it did take 24, 48 hours, but he went from being almost moribund to actually being fine. He's hobbling around now. And they're the people that they're all quite young, and they're the people that prior to COVID, it's that group of people that were they're still the SBE patients, the patients who've got bacterial endocarditis, the patients that have got community acquired pneumonia who end up on ITU for months on end, and they're a nightmare in ITU because they've got no venous access and everything else. So they're really, really difficult. But if you can actually intervene early and early stage, it can sort of help partly keep them out of hospital, but also to try and get them, build up their confidence in the system and build their confidence because they feel rejected by society, by family, by friends, by agencies as well.
Quite often, a lot of the clients they're estranged from their families now, so their friends are their families. So quite often I get referrals. The biggest referrals on our caseload are self-referrals, and second to that, it's their friends. Their friends will refer into the service and say, "Nurse Sue, can you go and see, Neil, or can you go and see John or Andrew? I'm really worried about him. He's not very well." And that's massive on our behalf, because if we didn't have their friends and acquaintances looking out for them, that they'd be really poorly because nobody else would. So it's really good that they can come to us and approach us and say, I'm worried about him. So I think that's a huge privilege, really, for me, Dr. Palmer, to be able to have them come and say that.
And statistically, if you've got a drug or alcohol problem, you're going to die 20 years younger. If you're on the streets, you're going to die another 20 years younger. So statistically, there aren't that many homeless people, in the sort of 40s and 50s who've been long-term homeless, because they do unfortunately have a really high mortality rate. But they're hard to treat, they're hard to manage, they're hard to treat. They talk about in the previous slide. They're talking about pain. In the previous talk, they talk about pain control, and pain control is an issue. I'm not aware of any addiction service that's at the moment willing to take on board people who are addicted to prescribed medication. So again, it can be challenging. And then when you've got people who are on methadone who break a leg or break an arm, they still need pain relief on top of their methadone, and it can be tricky from a general practice point of view. What do you do? From the addiction service point of view, they won't do anything else apart from prescribe the methadone, or obviously people on Subutex or buprenorphine, that's an opiate blocker. So there's no point prescribing opiates because they'll be blocked by the buprenorphine. So you have to think of other ways of trying to manage people's pain when they've got an acute reason for needing analgesics. the number needed to treat, if there's one slide, I went to a conference in London, the slide showed that if you treat 100 patients for blood pressure over 10 years, you might prevent 2 or 3 strokes. But if you treat 10 heroin users for just 1 year, you'll keep I think it's 3 of them alive, sort of thing. So there's a massive impact. The number needed to treat to keep somebody alive is quite significant. And a lot of our patients have quite childhood events, adverse childhood events. So a lot of them have been victims of abuse in the home situation when they're growing up, or have been homeless from quite a young age. We have treated 16, 17-year-olds who've been sort of street homeless from a young age.
And we keep a really good detailed data on our caseload, we do. And the reason for seeing that is to look at the trends coming through of substance misuse. And currently at the moment, we've got 2 sets of families, haven't we, Dr. Palmer? And the substance misuse and the drugs and alcohol started with Dad. And the 2 sons of these 2 gentlemen are only in their early 20s. And they too have got that learned behaviour now, and they're both substance users, aren't they, Dr. Palmer and the sons? Yeah. And it even goes out in one family, it goes out to the uncle.
And often they choose something different. They choose a different substance. So if the parents are alcoholic, then the sons will want to be. I could be more risky. I could be more dangerous, and I end up using drugs. I'm to be sort of heroin, then I'll use cocaine and crack and monkey dust, and it becomes they escalate the risks, really. That's
we started to treat the one dad on methadone, didn't we?
Yeah.
And we was hoping that the son would see that and it would rub off on the son, and he thinks, well, I want to be like Dad. No, I want the same script as Dad. So that would encourage him and motivate him to consider recovery with it.
And it's in treatment now, isn't it? But we're working with a number of different agencies. We work alongside STARS, which is the addiction agency, and there's people that won't engage with STARS but will engage with us. We work alongside there's other sort of street homeless agencies as well, and we're going to talk about Humankind Housing and Turning Point. We've got some representatives from those organisations in a little bit as well. One of the other points, following on from the other talk, is that patients can access online opiates and online benzodiazepines fairly easily. You don't have to go on the dark web. You can just Google it and you can have it parallel imported. So I appreciate GPs want to start reducing people and want to start bringing people down. But one of the potential outcomes may be that people start finding other sources of painkillers and benzodiazepines. It's something to be aware of, and it's something to check in with your patients if you're tapering down the doses to make sure they're not just swapping one source for another. It's obviously quite expensive, but if you don't have, if you just Google online benzodiazepines, it ends up being about £1. You can buy quite significant quantities imported into the UK from outside, and it's quite pricey, but it is a source. It's something that you need to be aware of from a GP perspective. And then obviously we all, a lot of the patients with addiction issues are struggling with monkey dust, because monkey dust is infiltrating into every drug system at the moment. So people that have been stable on using heroin for 20 years and maybe just smoking it or whatever, all of a sudden they're going psychotic because the monkey dust has got into the heroin, because it's been cut down to make the heroin appear more powerful, and they're going sort of psychotic and deluded, and so it's a real problem for both mental health services, who they'll just say it's related to drug misuse, the paranoia and the psychosis, and the addiction services will say it's a mental health issue, and the patients fall through the cracks. So the point of the Dandelion is really we're working those really difficult cracks where no other plants will go. But hopefully what you just like the Dandelion, what you try and do is change that local environment to encourage other services, encourage mental health services and addiction services to outreach into those cracks and help support some of those more vulnerable people, really. What's our coverage, Sue? What area do we cover? We've got GPs right across Staffordshire here. I'm conscious that.
Okay, well, what area do we cover?
Just Stafford Cannock Rugeley, really, isn't it? It's mainly South Staff.
It is Stafford Cannock and Rugeley mainly, but because of the nature of the service and the need out there, we don't refuse or decline a referral, do we, Dr. Palmer? We will go and see people in Lichfield or, you know, or Eccleshall or on the borders. Yeah. We've got somebody in Coven at the moment. So we won't, I mean, year before last, we was asked to support the palliative care team in Tamworth, wasn't we?
Yeah.
Because the substance user was end of life. And the district nurses and the palliative care team were very dubious about putting in anticipatory medicines into the shared accommodation. So they asked for our input. So we will do brief interventions. So geographically, our main caseload is Stafford and Cannock, Rugeley, but we will branch out if there's a need for us there.
And we keep getting told off because our caseloads, it's meant to be 25, 30, and it's now, how much is it now, Sue?
102.
Oh dear.
Yeah. Oh dear. So
102 from a GP perspective doesn't seem too bad, but from a mental health team perspective, you know, we've got more patients than the crisis team have at the moment. So
yeah, we have. But it sounds daunting, 102. But like I said, the diversity of it is you've got somebody that just needs that one phone call or one visit fortnightly to monthly to keep their head above water, like Dr. Palmer says, and then you've got the ones that need Monday, Wednesday, Friday visits because they're quite active and they're quite dependent on you for their support needs. So we're not seeing all 102 a week. However, we are supporting 102 people over the month and encouraging them to use other mainline services as well. We're not a replacement service, are we? By no means. And where we can encourage the patients to re-engage with services, we will do. Yeah.
Sorry to interrupt that point. Sorry, David. There's a really apt question there from Sharina about sort of wraparound services there, which might fit into your discussion at that point in the chat, if you just want to have a quick look.
Yeah, absolutely. Yeah, depending on the locality, it's about the wraparound services, social support, drug and alcohol services, other sort of charities, housing support, housing education, mental health services. In theory, everything's meant to be integrated. In practice, these people are still falling through the gaps. So we'll steer people to the most appropriate person because we work alongside. It's probably a good time to bring in Carla from Humankind Housing or Nick, and they're, or both actually, and they're sort of influential as well at trying to sort of link people into what other services are available for any one area. So it's to try and plug the gaps in the system, and unfortunately there are gaps in the system that people fall through. Carla, do you want to say a little bit about your Humankind Housing and yeah?
Yeah, so when I originally started about 2 years ago, so we only had one property and it wasn't ready to let. So we started to branch out and get to know our referrals and the sort of people we'd be housing. And we've got 5 currently now. That's all the properties we've got. But the problem with every single one of them was they didn't trust anybody. They wouldn't keep up to date with their appointments. They didn't trust the general GPs anyway. They didn't want to be around those people in the surgery because they felt like outcasts. And that was the trouble. So then with that, from a housing perspective, it was their income. They were being sanctioned because they weren't getting their sick notes from the GP. And it was quite a mess when I first came in, and it opened my eyes because I weren't expecting it to be so problematic when it comes to obviously the addiction and the repercussions of that. So all of my tenants, obviously now I've got them into the property, they're struggling to maintain because of their addiction, and they've all suffering with mental health, and it's the mental health that's stopping them from moving forward with life. And just going to like the outreach services like Cannock Chase, Chase Recovery, they don't trust anybody. So Dr. Palmer was a lifesaver for me when it comes to all of my tenants actually, prescribing them. Obviously Dr. Palmer then liaised with the doctors that they already had that they weren't attending. So without Dr. Palmer, I wouldn't have any tenants. They would have all been evicted by now. And obviously I've got one empty property now because one tenant I had, the monkey dust, literally took her life. She would have been, I would say, probably months away from death if
It's an interesting case. Nikki is a insulin dependent diabetic, and who a GP wasn't in Stafford, so that made added complications. When she was using monkey dust, she didn't inject insulin, and the temptation was at times previously she had injected illicit substances like crack or heroin, but she mainly switched to just monkey dust, and her blood sugar levels were all over the shop when she was using one that. So she's at a huge risk of going to sort of ketoacidotic coma.
She was even scared to use it because she thought it had been contaminated by somebody because of the dust use, and then she'd use somebody else's. I think she didn't use her insulin for about 3 weeks, and obviously her normal weight was around 11 stone, and I think it went down to just below 7 stone.
Yeah.
So it was hard, but Dr. Palmer obviously came out to see her. We couldn't get her into rehab because they said that her health was that poor. So we were in a catch-22 of how do we get her health better without rehab? We couldn't get her better in the community. So it ended up with her, obviously, hospital, and she stayed in hospital and was discharged to her mother's house. But again, she wouldn't go to the GP. So Dr. Palmer went to her mum's house.
She did things like blood tests. She wouldn't go to GP because she knew her veins were awful, and she wouldn't trust anyone else to do the blood test.
They couldn't get it.
Good use of my time to sort of go and do a blood test, but actually got her into BAC because we had to prove to the BAC that she wasn't in renal failure or wasn't in liver failure, and with a lot of persuasion, persuaded them to have her in. She's been there 6 weeks now.
6 weeks, yeah. I went up to see her on Saturday, and she's doing great. Yep, she's 10 stone now, and yeah, she's really thankful. She's quite apologetic for us all having to see her in the state that she was in. She realises now how bad it was, but yeah, she's thankful for the help and support, especially from Dr. Palmer, because she wouldn't be there, without that.
It's got a future back entry, so
it
makes it worthwhile.
She's got dreams in that now, and she's looking forward. Definitely.
I remember when at one point she was so poorly that Humankind moved her into the Travelodge in Rugeley, and she was there only for a few days, and then she still went out and tried to find some monkey dust in Rugeley, which is not as easy to find as you'd imagine it to be, but she managed to find some. So Carla's influence is fantastic. It's getting people on side, because these people have often, like Carla said, don't trust any organisation. They feel they've been shafted by addiction services and shafted by mental health services. So it's often that individual relationship that makes a difference, and certainly that relationship with Carla is massively important. And another street services, Turning Point.
If I could say a little bit about Turning Point, we've been on quite an interesting journey over the last.
Nick, we can't see you. It may be that your screen thing's going across. That's it. I know. Now, Turning Point was in Stafford, 20 odd years ago, and I remember chatting to somebody from Turning Point. Is this before shared care started? And at the time, the only way of getting a patient on methadone was to pay for a domiciliary visit, and it was shocking. And Turning Point was saying, well, why can't GPs prescribe? And it's before all the RCGP Part 1 certificates in supporting substance misuse. So it's a long time ago. And then sort of Turning Point disappeared out the air, and now it's back in again, and it's again making great inroads. So tell us about Turning Point.
Funnily enough, Dr. Palmer, I used to work for Turning Point about 20 odd years ago in Newcastle, and I think it's probably part of that same team because they had DrugLink in Stoke at that time. All the shared care and the GP special into gypsy clinics and all that kind of thing. So Turning Point in Stafford, we've been on quite an interesting journey over the last couple of years. I started in January 2023, and we started to develop a supported 6-bed supported accommodation service, which was to be meant for people with multiple exclusions. So long-term homelessness, substance misuse, mental health needs, multiple exclusions. The people who really struggle with any kind of other accommodation sites, people that have been in and out of lots of different hostels, night shelters, private lettings, councils and that kind of thing, but don't really manage to get through those.
One case is a gentleman who at 3 o'clock in the morning, he'll shout out. At 3 o'clock in the morning, he'll have a nightmare, he'll have thoughts in his head, and he'll feel like, whether he's getting flashbacks or whatever, he's out there shouting out, and go away, and he's at top of his voice, and he's disturbing everyone else that's in the hostel or whatever. And so sooner or later, he ends up being evicted, doesn't he? So, and he's been on the vulnerability hub list for years, and mental health teams say he hasn't really got a mental illness, even though he's walking on the dual carriageway, talking to voices in his head, and addiction services saying, well, he's not really got a dependency, because he doesn't, but he does still dabble in drugs when he feels like it. And he's stuck in the crack, isn't he?
And he's I think Suzanne, you've known him for probably 20 years or something like that, or maybe a bit less than that, and he's been in and out of services forever, hasn't he? Been known to services and always talked about, and the sort of the actual cost of him as well on the public purse, so your police and your health and all that kind of thing. And of course the guy is stuck. When we picked him up, our service was delayed quite considerably because we struggled to get a property in Stafford. So I had already built a team, and so we started with the other arm of the service, is a co-production project, which is trying to get the lived experience of people who've experienced homelessness to try and develop homelessness services and associated services to more meet their needs in the community. And what we did, we started to develop lots of links with House of Bread, Dr. Palmer, other services like churches, etc., and really engaged with the homeless population. We had quite a lot of tent encampments at the time, so we were going out and seeing people in person out there. And this helped us to really make good engagement and good trust with the people that we were working with. And we started to assess around about 16 people. And over the space of a few months, we've assessed people, and as basically we supported some of them to access other accommodation and supported them to access that accommodation with the lower needs. And then we were left with a small cohort, which was going to come to our accommodation in the end. We opened our supported accommodation in February this year. And it's taken us about three months to get up to full. And we're now full with six people in the service. But if you think about it, there's 6 people who have got undiagnosed mental health needs, unmet trauma, quite interesting views, very entrenched behaviours, interesting views on social relationships, and as a team, we're constantly attempting to break down those boundaries and barriers build the trust necessary, and help to help them to access the other services which could help them to improve the circumstances. But we do find some. So before we opened the service, we had partnership events where we went out there and we pulled in other partners, STARS, the Drug and Alcohol Service, local borough council, the county council, health services, housing services, just to try, mental health services, to try and provide that sort of network. Everybody that we pick up, we'll have an MDT before we house them, and we're trying to sort of progress them along the lines of this MDT. But a lot of times, as Dr. Palmer said, we find that the person might be a bit reluctant to use services, but it's probably because their past experiences of using services and the services haven't fit them. So, you know, we've got a gentleman here who he's hearing voices, and we see that regular. You know, when we're sort of trying to provide access into mental health services in a way which meets his needs, that he's not fearful of, to try and help him to move forward, because alongside that there's a high degree of alcohol use, and all the associated things that come with that. And then there's monkey dust, the NPS known as monkey dust, that's quite prevalent in the area. And all these things, they cloud the sort of the judgment and the assessment of the services, and we find that it's really quite, you know, we're trying to sort of fit a sort of round peg into a sort of square hole, and we utilize, you know, Dr. Palmer's amazing in terms of allowing us, you know, support, access, emergency support when all else fails, but also that support to try and access, you know, because the ideal scenario would be that somebody that we work with gets ongoing long-term primary care and secondary care, you know, which meets their needs.
Yeah, and it should be wraparound, shouldn't it? Like Sharuna said in the chat, it should be a wraparound care where everything's there, focus around it, because actually this group of patients are probably, you know, each individual is probably causing 2 or 3 admissions to A&E every week at least, plus a huge amount of police time, plus a huge amount of mental health time and addiction services time, none of which was actually gaining anything, because actually they wouldn't respond to telephone calls, they wouldn't respond to, you know, we even had one patient who was sent even though he was homeless, was still sent a letter to attend at 9 o'clock, and I don't know where they sent the letter to, but the services under pressure seem to want to deflect patients away, and these patients are deemed to be time consuming.
Yeah, there's a thing about you know, people that are on orders and they can't go to places. We've had people that have got, you know, they might have a benefits claim, but they can't go anywhere near the you know, the
town
DWP town centre, so they can't go to the benefits office. And these you know, they've already got a lot of barriers. So trying to navigate those systems, like, but you know, we've been open now for, you know, just over 4 months, and we've got some people who've been here all that time, you know, and that's compared to maybe sometimes they've done 4 or 5 days in some places. So we have a different approach. We don't want to be a hostel. It's their home, and we strongly believe in opening up that dialogue so that they feel, you know, a strong sense of ownership in the place. So, you know, having an ongoing dialogue, rather than sort of enforcing rules that they don't understand or can't actually adhere to. Trying to have that ongoing dialogue, which we build an understanding between us of what is acceptable in here, and what, you know, and we navigate that together. You know, it's sometimes, you know, we have some challenges here, but you know, there's loads of positives. You know, we had one gentleman who, after an attack of pancreatitis, he went into hospital. He remained alcohol free for 2.5 weeks, which is massive for him. He hadn't done that for, you know, 6-7 years, you know, and it's, you know, it's huge, that is, but it's what's the next step from that? What's the next step from that?
Then he has a lapse, because everyone with any addiction, there's always a lapse. If you're trying to stop smoking, very few people suddenly stop and never have a lapse on it. So he had a lapse where he drank for 2 or 3 days, and then he's back on the wagon again, isn't it? And that's massive, you know, massive improvement. And for someone who's, you know, every day when he was homeless, he was, I think it was him, he was under the bridge and the head wrapped in his sleeping bag. You know, it's a shocking state.
Yeah, and he's withdrawn. You know, I remember seeing him last June, and he was so withdrawn while he was on the street. He was just disenfranchised. He'd lost everything. He couldn't give you eye contact. He was just in himself and just really withdrawn. And he's like a different person. He had been beat up a few years ago where somebody hit him with an iron bar in his teeth and lost all his front teeth. And now he's got new teeth. He's got some new teeth. We got him to go to a dentist and that. And you know, some of these things, it might feel small, but this could be a massive thing that helps him to build his confidence and start to do something different. You know, we're very hot on trying to re-engage people with positive support networks. So whether that's family, friends, trying to build that support network. We got two of the guys out today. At the farm, we got a farm that they go to once a week, and they look after the piggies and things like that and stuff. And some of these things, you know, filling your time, it's super positive, you know. So, you know, I think we need to look at things in a different way. You know, look at things in a different way, but you know, keep doing what we're doing.
I think the big thing is Nick is looking at their achievements rather than our own service achievements and what we're achieving.
Definitely.
Looking at what they're achieving, because like you said, the little achievements and praising those gives them the motivation and the inspiration to carry on. So something as simple as having a new set of teeth, you know, changes their self-worth, doesn't it?
Yeah.
So it's for me, it's important to look at their achievements. You know, 2 weeks being dry and off alcohol is massive to somebody that's been drinking for 10, 15 years. It's fantastic. Yeah.
So a good example is where we've utilised your services are somebody who's on buprenorphine and he's regularly falling off script. So we had an issue where he fell off his script around a bank holiday, and he was in kind of free fall where we couldn't get him an appointment for another 2.5 weeks. And at that point, he would have to use heroin for that time, and that could really knock him off. So we worked with Dr. Palmer, put in a bridging script, and just to keep him on that, to keep him stable, and then re-engaged him with the service that he's with. And it's that flexibility, isn't it? It's having that flexibility and seeing what can we, rather than the computer says no, think about what can we do, what's good and what can we do to make it work,
Mm.
Yeah, absolutely. And it's often the little things, isn't it? The little things that people go next to Maya, like Carla going to see Nikki in the BAC, extra just having that little bit of time to listen to people's worries and concerns and put everything in the individual's perspective does make a difference to people who would otherwise be another sort of homeless statistic, another drug-related death. And drug-related deaths are an all-time high. They're as bad as they were when 20 odd years ago. I worry about the future. I worry about what follows monkey dust, whether there will be a fentanyl epidemic coming through or these novel opiates that are creeping into the system, because I think they'll wipe out a whole lot of
nitrines, those nitrines things.
Yeah,
they're coming in, aren't they? Yeah.
They'll wipe out a lot of heroin users, but they'll also attract new opiate users. Heroin's seen as a bit of a loser's drug at the moment, so there aren't that many young people choosing to use heroin. But they may be enticed to use new opiates because they sound a bit more sexy, sort of thing. So I worry about the future. I worry about what's happening with deprivation, and obviously the state of the country is is more children who are living in deprivation than there were in Victorian times as a figure. So we do need to look up for families. Part of my role within NHCC as sort of head of school for GP training has sort of helped lead up health equity focused training in the West Midlands. So we're trying to train GPs to have a health equity focused way. What groups within any area are disenfranchised. What groups do find it difficult to access primary care. And it can be reasons of having mobile phone, or it can be because they've got hearing impaired or deaf, or it can be a travelling community. and obviously one of the recent challenges were asylum seekers, and I appreciate some areas managed the added numbers of with hotels with full of asylum seekers. Some managed it better than other areas, but it did create a huge pressure on services with people who are quite traumatized by their experiences, both in their original countries, but also on the journey across from across the Channel and across the Mediterranean as well. So that they're quite tricky. Thanks, Carla. Thanks, Nick. Thanks, Sue. So that's a little bit of what health inclusion does in the sort of South Staffordshire area. I appreciate it may feel a little bit distant for people in North Staffs or other parts of Staffordshire. I think it's a service that could be replicated elsewhere. I think I'm the only GP I know that's employed by a mental health team, a mental health trust as a GP to support mental health teams. That in itself has caused a lot of challenges within the trust, because actually GPs do what GPs do, which is sort the problem out by and large, and we don't necessarily do what trust wants to do, which is follow guidance to the letter. All of my patients wouldn't be in treatment if I followed guidance and standard operative procedures to the letter, sort of thing. By definition, they've fallen in the cracks because of the standard operative procedures haven't caught them.
Has anyone got any questions? Yeah. Yes, I was going to say.
Sharon has talked about adverse childhood events, which are a massive issue, isn't it? And often linked to deprivation, often linked to sort of domestic violence in the home, and it's a real challenge, isn't it? And they unfortunately, people who've suffered all these adverse childhood events then have issues at school, and then have issues. They get accessing CAMS and accessing appropriate sort of mental health support at an early stage, and then end up being given a label of emotionally unstable personality disorder or borderline personality disorder, when actually they're probably just mixed up kids who are now mixed up teenagers, who are now mixed up 20-year-olds, and it's really hard then to roll back the clock. It's really challenging. Self-medication is an issue, isn't it? Self-medication, whether it's in like illicit drugs or alcohol, is a massive problem. And they also seek they end up on antidepressants and end up on painkillers for what's often emotional pain, and that sort of leads on to sort of chronic issues.
I think one of the things that I'm really interested in this area, but one of the things that strikes me is I don't know whether childhood adverse events are assessed in general practice, to families and children. And I think it becomes an issue because it's not found out earlier enough, that it's later on that stop using the services because of events. And I just wonder, from GPs, do you assess adverse childhood events, assess, those things, with families, or assessment? I don't think it's done, is it? In America, I think they do try and encourage that. Every time they see a child, they ask, those questions, and, try and figure it out. Anyway,
we're often aware of it, aren't we, with continuity of care, and appreciate continuity of care is harder to maintain. But as a partner, who's a partner over 20 years, you see the kids who've had problematic childhoods, and you see them sort of develop and into adults with issues.
I think we're just starting to get into that sort of trauma-informed care, aren't we? I mean, we're obviously behind social care as well, but it's a developing field. But I think we've lost some of that continuity. I can see Ruth's got a question actually, so I'll be quiet.
No, it's all right. I was just going to ask, do you have much involvement with the military side of things in Stafford? Have you noticed?
We haven't had
that.
Yeah, we haven't as such as yet. No. We have had a few veterans who have come to the food bank, and they're often quite humble and reticent about talking about their military sort of service, but because they're there at a food bank and their lives may be from their perspective being a bit of a mess, and whether it's drink rather than drugs. But yeah, Nick, do you want to jump in? Or
I was just going to say we've got 2 people in the service out of 6 people. We've got 2 that were former forces, which is really good, you know. But I'm desperate to make better links with you know, all the support services which are out there. It's funny enough, they're quite reluctant to access, you know, the usual, the British Legion and, you know, Stafford, etc. at this moment. But you know, it's an ongoing journey, isn't it? But you know, there's a huge amount of people that's been exported that are on the streets. We see it massively, you know, in terms of the outreach work that we do.
So they say 2,000 veterans, 2,000 ex-servicemen are homeless at the moment. And I went to there was a homeless worker from the northeast and then she's set up in Newcastle, which obviously supplies quite a lot of soldiers to the British Army. And she's literally did a smoothie cafe, and she's just engaged at whatever level these homeless servicemen who wouldn't eat anything and just relying on drinking whiskey and Newcastle Brown sort of thing, and she engaged them at that level, and she's trying to and just that bit of kindness, that bit of understanding helps someone sort of get off the streets and sort of turn their lives around. So it is a massive problem, and I'm conscious it's the anniversary of D-Day today, and you know, and well, yeah, the veterans will get £9 off a veterans rail card, but there's 2,000 that are homeless. You know, it's great.
Any other questions, or can I just remind people that the link for the feedback has just gone into the chat, so there's a SurveyMonkey link there. We're very grateful for your feedback. We do look at in depth. And can I thank David and everyone else that's come today, and I'm really grateful. So Sue, Carla and Nick have just spoken then, but also to our previous speakers as well. I think it's been a fascinating afternoon. It's really highlighted lots of things that that have sort of that we need to take notice of in the area. So can I join everyone saying thank you very much? And I know I owe a lot of favours because I have asked you all at very short notice. So thank you very much indeed.
It's been a contrasting afternoon, hasn't it? It's going to be really challenging to reduce opiate prescribing in general practice. I think we have to make an attempt. I think there's a lot of patients who are stable on their opiates who don't want to reduce, but we're going to ask the question. Yeah, absolutely. And I think that's sort of perhaps not starting them on it is maybe where we need to go in the first place. Keep away from oxycodone and fentanyl.
Yeah, it's my take home message. Yeah. Thank you for putting those links, Nick, for places in Stoke as well. That's really good, really helpful. So I think well, we're just up to 4 o'clock, so that's brilliant. Thank you very much for your time, everyone. I think everyone's putting thank yous in the chat for you, but we'll pass all that on for you. And we got to the dizzy heights of 102 people at one point this afternoon, so that's really good. Yes, lots of thank yous.
It's an important time, and I think general practice is at a turning point, isn't it? We do need to we do need to sort of decide where general practice is going. It'd be a shame if we did lose some of the values that are part of general practice.
Yes, and I think that's where some of the loss of trust has come actually, isn't it? Because it's a different person they see each time, and somebody does something slightly different. So
it's scary how many names I recognise on that list. So yeah. Thanks for inviting us.
I think it worked well, as you say, David, to contrast to the bits, but it actually fit together very well, actually, didn't it, in lots of ways.
Sheena, can I just ask you about the training hub?
Yes.
I was quite interested in the Schwartz round, and I'm really excited about that. About setting that up in primary care, because I've seen it operate in the trusts, and I've had the feedback from one clinician's talking about a personal thing, and I found it fascinating. It was really, really insightful, and I'd love to work with you on that. So I think you've got one in May, haven't you? Coming up.
We've got, well, hopefully it's June because it's next week.
June, sorry, June. Sorry,
Yeah.
not May. Sorry, June. Yeah.
Yes, we're doing one in Barton Marina next Tuesday, and then we're going to run one on this session in November as a trial. Yeah, so we're trying to get it established in primary care. But I think we're the first training hub to try. There was one in Kingston who started about the same time with us, but I'm not sure they've got it off the ground. But have you had experience of running them, Sharon? Are you a facilitator or?
But I mean, I understand the principle of it, and I think I heard one of the A&E consultants after the Greenfall incident. He was the recent consultant on that, and he experienced that, and then he was then talking about the impact of that trauma on him, and then how it affects. And it was a very powerful dialogue because it talked about how vulnerable as health professionals we are in this, and how it's sort of how we get resilience. And I think that's why I'm interested in it, because it's about what health professionals do for each other here, and support them in resilience and good work, to continue in their career. So having an opportunity to share some of that I think is very powerful, and it takes a lot of bravery and courage to do that as well. It's testing it very, very in a different way. So it'd be wonderful to work with you. I'll help you in whatever way, Sheena, if you want. Yeah, absolutely.
Oh, fabulous. Better still.
Anyway, I think it'll be interesting to model and evaluate. I think it'll be good.
Yeah. So we're doing the one we're doing next week is about difficult conversations, and one was about a social prescriber trying to get a house for somebody to live in who was homeless and palliative care, and the frustrations he had trying to get through the system. So sometimes it doesn't always have to be sort of major trauma. It's just sort of we can all resonate with sometimes the frustrations. Dave in particular is nodding. The frustrations of trying to, when there's a right thing to do, but you can't get it done, isn't it? But
I think it exposes the gaps that you've got in the system, but I think mostly it exposes the frustrations that you have in terms of trying to do the job that you want to do, and how it impacts on you. Yeah, that's good. Well, I'll try and get onto it if you let me join, and then
absolutely. Well, the next one's in person, so it is actually in Barton Marina, but the one in November will be online. So I'm presuming an online one would be better for you, given your schedule, Sheena. I'll pass you the invite anyway.
Yeah. Okay. Thank you very much.
Okay. I think almost everyone's gone now. I'm going to say goodbye to everyone. Thank you very much. And just a reminder that it's voting day next PLT session, but please come along because it's Red Whale, and it will be really good as well. Thanks very much.
Okay,
Thanks,
you.
Dave.
Bye.
Bye.